Good morning. Today we are going to discuss about the intraoperative and postoperative applications of T, which is a continuation of T series on pediatric T series. So let's discuss a case first. A 3-year-old child weighing 12 kg with a diagnosis of perimembranous VSD, mild pulmonary hypertension, is posted for elective VSD closure. In pre-op transthoracic echo, we have a 4 mm, 7 mm perimembranous VSD with left to right shunt with good biventricular function and trivial aortic regurgitation. Now the child underwent uneven full VSD closure on cardiopulmonary bypass. After separation from CPB, blood pressure is acceptable on low dose milrinone and surgical inspection suggests an adequate closure. Okay. Now let's assume that we have not inserted a T in this patient. Now after once the patient has come off, everything seems good and we are about to close and shift the patient. Okay. But in this patient we have inserted a T. This is the T. Now as you can see, after coming off we are assessing the T and we find a residual VSD. On the top of that there is also aortic regurgitation along with the VSD. So now the plan is changed. At this moment the surgical, we were ready to close, but now because of the T finding, the decision is made to return on CPB and VSD patch is revised and aortic cusp is resuspended. Again patient came off smoothly, no issues. On repeat T we find no residual shunt, trivial aortic regurgitation and preserved ventricular function. So intraoperative T not only confirmed the repair, but it changed the outcome of the patient. So if we didn't have T, the patient would have shifted to ICU, and on post-op day 1 or 2 we would have diagnosed VSD, and then there would have been plan to repair, or it wouldn't have been. But we have T in the intraoperative period and it changed the diagnosis. We directly went on pump, and at that particular time in that setting we had a change in outcome. So T is essential in congenital and pediatric cardiac surgery. It can be used intraoperatively or postoperatively, and it gives a real-time anatomical and hemodynamic assessment. Now as we know already, we have different T probes available. So initially, if we go historically, they created a monoplane T probe, okay, which give us a T image in just one plane. Then came biplane, okay, 0 degree, 90 degree. In between we don't have anything. Then came multiplane, in which we can get the 360 degree view of the heart. In one sweep we can get 0 to 180 degree, and if we turn the probe we get another 0 to 180 degree. So in that way we get the 360 degree view of the heart, and it helps in improve image quality, diagnostic accuracy, and it helps in improving the outcomes. So there are different types of T probe. Now recently we have there are neonatal micro multiplane probes which are coming up. So the pediatric probes, so the types of T probe basically depends upon the elements, so the number of elements which are present in the transducer. So there can be around 30 to 2500 elements. So newer 3D probes have around 2500 elements, but the pediatric probe they have lesser elements, maybe 32. Adult will have 64 elements. So depending upon the elements, it will give us the image clarity, and so it depends upon the image output. It depends on the elements. So the if we try to insert a pediatric T probe in a neonate, there can be a bronchial compression, or in case of TAPUC there can be obstruction of the common chamber. So in order to avoid that, the newer neonatal T probes have come up, which are just size of about 5 mm in diameter. So these are the various sizes, various types of T probe. No, so as I already told you, depends upon the weight and weight of the patient, and we'll select the T probe. Now the standard view is mid-esophageal 4-chamber view. This is the mid-esophageal aortic long axis view, and this is a RV inflow outflow view. On the top of that we can use other views like bicable views and other modified views. So as we come to this basic T views, so as we know already, this is just a revision. So this is a RA, this is a LA, this is RV, this is LV, interatrial septum, interventricular septum, this is a tricuspid, this is a mitral valve. So this is a standard 4-chamber view. If we just have this view, we can assess lot of things. So in just one view we can assess the regurgitations of the mitral valve, tricuspid valve. We can also assess the function to a great extent, and also other findings like interventricular if any VSD, if any ASD, and just by getting the different views, we are just improving our image quality, and we are improving the diagnosis and confirmation. So we can use all the T views and confirm, and also can get other findings like additional VSDs, etc. So in surgical management, we can first confirm the diagnosis, we can guide the surgical plan, assess the adequacy of repair that will be in the post-op, and determine the need for re-intervention or return to bypass, as we have discussed in our case. So in valvular disease evaluation, so we can see the mechanism of regurgitation, which is central or eccentric. Now stenosis assessment, valve area, gradients. After, again, we can assess the prostatic valve function, if leaflet motion, residual shunts, and guide annuloplasty procedures. So in repairs, T is very essential for pre-op and post-op assessment in repairs. And post-op repair assessment of coaptation and leaflet, we'll discuss it further. So these are the basic views and modalities. So this is a mid-esophageal 4-chamber view, and this is a aortic long axis view. So this is just this is showing this is the mitral valve, which is showing the regurgitation jet. So this is a mitral regurgitation jet, and we put the continuous wave Doppler. So this is a continuous wave Doppler sample of the mitral regurgitation. Here this is the slide which is showing the vena contracta. Now so we can use various methods to assess the severity of the MR. So based on the continuous wave Doppler, based on the gradient, based on the maximum velocity, based on the vena contracta, and this is the image showing the Tee-Cce. So proximal isovalvular velocity area. So by using the various different methods, we can assess the severity of MR. And this is the showing the pulmonary vein waveform. So in severe MR, we have systolic flow reversal, which can be which can help in assessment of MR. Now again, this slide, as I told you earlier regarding the repairs. Okay, so this is a mitral valve, this is the AML, this is the PML. Okay, so from this point, this AML and PML will meet at point, okay, which is a coaptation point. So okay, so from this point to this point, this is the coaptation distance. So at which point the coaptation is happening. Now we have other measurements like coaptation depth, and we have coaptation length. So the length, coaptation length is basically the length of coaptation between the, so that is the point of contact between the AML and PML basically, and depth is from the level of the annulus to the point of coaptation, that is the coaptation depth. So these are the measurements which are very essential for repairs. So pre-op, if it can be repairable or not, and after the repair, if it is adequate repair or not. Now impact on surgical outcomes. So surgical management, it improves the alters the surgical management 1 to 13% of cases, and return to cardiopulmonary bypass in 3 to 7% cases, and it helps in reducing the perioperative morbidity. Now also helps in catheter guiding the catheter placement. Okay, so T enables precise, safe central venous catheterization, complex anatomy, visualize the central venous catheter insertion and tip position in real time, avoid malposition in pediatric congenital cases, and prevent the cardiac perforation. Okay, so this is a slide. So this was a case in which we were doing a mini ASD closure. Now this is a there is a ASD. Okay, so when they will cannulate, when the surgeon will cannulate from the using a femoral vein, they'll insert the guide wire, and the guide wire has to pass into the SVC. Okay, so this is a bicaval view. This is a this is here is the RA, and this is the interventricular septum. So the guide wire and the catheter and the cannula was going into the into the LA through ASD, but it's supposed to be there in the SVC. By the means of by using T, we guided the surgeon and helped in inserting the cannula into the SVC. Now here we can see the venous cannula going into the SVC. So this helps into the helps in cannulations. In congenital heart diseases, we can assess the anatomical variance. So in some cases, in preoperative thoracic transverse echo, few findings can be missed, which we can find in the intraoperative Tee-Cce. Okay, so anatomical variance in associated lesions. It can help in adequacy of repair intraoperatively, detect the residual shunting, guide catheter and device placement, and early detection of complications in hybrid procedures. About the anatomical variance. So this is a EAT image showing the dilated coronary sinus. Okay, and so this is a midesophageal coronary sinus, and this is midesophageal port chamber view showing the left SVC. Okay, so this is a structure which is the left SVC, which can be seen in the left in midesophageal port chamber or 5 chamber view. Now also it helps in assessing the ventricular preload. Okay, LV and diastolic area, volume assessment, and qualitative and quantitative measures can be done to assess the preload of both the right and left ventricle. Okay, there is a slide showing the IVC size and IVC collapsibility, which helps in interpretation of the CVP. Now this is the T image showing the inferior vena cava. So this is a modified view. So this is a transgastric view at around 40 to 45 degree with the anti-flexion and rotation clockwise. Anti-clockwise. We can get the inferior vena cava. So this is the IVC. This is the hepatic vein opening into IVC, and they both will now open into the RE. Assessment of left ventricular systolic function using fractional area change, ejection fraction, ball motion analysis, and strain and rate imaging. Now these modalities have been discussed in other previous classes, so we'll not go into much detail. So this is a transgastric visual short axis view showing the RV and LV. In this view we can assess the LV feeling. Okay, so we can compare the diastolic and systolic diameter of the LV, and we can which will help in the assessment of the volume assessment, which is also a good measure for both directed fluid therapy. Also in this view we can put the M mode and help measure the ejection fraction. So in it helps in hemodynamic management. We can optimize the preload contractility and afterload using T, and it helps in guiding the inotropic and vasopressor selection. So we know the EF, we know the volume. So by comparing all this thing, IVC diameter, ventricular volume, ventricular contractility, ejection fraction, and the hemodynamics of the patient, it helps in us in selecting the inotrope or vasopressor which is needed for the patient. So in case there is less contractility, then we can use the inotrope. But if the contractility is adequate, and if there is adequate preload as well, then we can go to the vasopressors. Also, if there is low preload, then we can give a volume fluid challenge and then check for volume response. Impact on anesthetic and surgical management. So as I told earlier, it guides in inotropy and vasopressor strategy, direct the surgical revision for adequate repair, and optimize the mechanical support. So in case we require any mechanical support in the form of IVP or ventricular assist device, then we can make that decision using the Tee-Cce. And also I want to highlight here, by using the Tee-Cce or goal directed fluid therapy, we can do the VTI of the in the aortic wall VTI or LVOT VTI. We can measure at, if there is any difference more than 20%, then it is the patient will be volume responsive, and we can give the volume in that patient. So basically what we will do is, we'll give a leg rise. We'll use a leg rise, okay. By giving a leg rise up to the 45 degree, there will be increase in the pleura to the heart, and the contract and the blood pressure will improve. Simultaneously, what we are going to do is, we'll measure the VTI in the LVOT before and after the leg rise test. And if there is a difference in the VTI by more than 20%, then it is a good indicator of fluid volume responsiveness. So Tee is very cost effective, and it, as we have seen earlier, it will alter the it will alter the outcome, and hence the cost as well. It reduces the revision rates by detecting inadequate repair, prevents post-operative complications through early interventions, decreases the ICU time and hospital length of stay. In our in our patient, the ICU time would have been increased, okay, if we would have not prepared the VSD at that time. So it has an extra burden on the hospital and society. So these are the key scenarios where we can apply Tee-Cce in valvular cases for the assessment of the leaflet geometry and coaptation. In congenital heart disease, confirm the anatomy first and then detect the residual shunts in the post-operative period. And hemodynamic instability, as I discussed earlier, and in high-risk patient, to optimize the pleural contractility, and if there are any unexpected findings which can modify the surgical approach. So as I showed you the left SVC, the T image of showing left SVC, okay. So intraoperatively, when we detect the left SVC, that time it changes the cannulation strategy, okay. So it modifies, or it will change the surgical plan. Now three-dimensional Tee-Cce can be used, though its use is limited in the pediatric population. When there is a bigger and there is a older child which with adequate weight comes for the surgery, we can use Tee-Cce, but it is not in low weight pediatric population. It's the use is still limited. But Tee-Cce is 3D Tee-Cce has in real time. It improves the image quality, and it will complements the 2D imaging. So these are the few other images which are shown. So so its application in the post-operative period. So in the patient which with a hypotension, with raised CVP, okay, reduce urine output, we can if there is a inadequate transthoracic window, then we can put the Tee-Cce, and it can help in assessment of what exactly is happening with the patient. So in this patient, there is a pericardial effusion, okay, which is compressing the heart. Now so this is a Tee-Cce image showing the This is a RB inflow outflow view. So aortic valve, this is a RB. So this is a VSD. Okay. Now we have put the color flow Doppler here. So this is a perimembranous or inlet type of VSD. So again, to confirm the diagnosis, we have to assess it in different planes and different this is a image showing the pre and post-op repair. So pre-operatively we can see the VSD flow, and in post-op there is no flow, and we can see the patch. So there is no flow across the patch in the post-operatively. So these are the 3D images. So this is the interatrial septum. This is the image of left atrial appendage. Again, if there is any clot, then in post-operatively if there is any air, we can it helps in assessment. Now this is a T image of the native valve. This is a mitral valve, which is open. This is a closed mitral valve. Okay. So this is a AMN, this is a PMN. Now this is a prosthetic mitral valve in closed and open position. So it helps in assessing the leaflet mobility. If you put the color on Doppler here, then it helps in assessing the paravalvular leak as well. So now key takeaway: T is a standard of care in congenital heart surgeries. It improves diagnostic accuracy and surgical decision making, and advances in technology continue to expand its role. So we have seen in 3D imaging, it gives us more valuable information than 2D, but again it complements. 2D remains the standard of care, and 3D complements the 2D imaging. Thank you.